This is the lecture for Chapter 6, Nursing Care of Mother and Infant During Labor and Birth. So if you have your worksheet handy, there's a lot of things that you should add from this lecture. If you don't, pause this video for a second and get it. All right, so Chapter 6. We talked about culture a little bit, and this is part of your cultural assignment. Make sure that you know that the care that's given to the family is specific to that patient. It's not going to be the same care that you would give the last patient or the patient down the hall or the patient 3 months from now. Everything in nursing should be very specific to that patient. That's what patient-focused care is about. The 4 Ps, this is something that you need to know. This is in your worksheet. So if you have it, make sure you fill in what the 4 Ps are and look these up on page 126. Uterine contractions. This is page 126 to 128. These are the updated pages. Effective contractions on the cervix. So the first part of labor is getting the cervix and the uterus ready. So effacement is when the uterus, the cervix is thinning out, and dilation is when it is opening up. So uterine contractions, this is what their whole job is: effacement and dilation. The phases of contractions are increment, which is when the contraction is increasing; peak, when it is at its strongest point, just like a mountaintop; and then decrement is the part of the contraction where the contraction intensity is decreasing a little bit. So the beginning of the contraction is the increment, and the middle is the peak, and the end is the decrement. And then there's a phase in between where there isn't a contraction. So frequency and duration, these are 2 concepts that you need to know. Frequency is how often they're occurring. And we're going to talk about this again in a couple slides. Duration is how long one contraction lasts. So if you have a contraction that starts at 5:05 and it ends at 5:10, that duration is 5 minutes. If you have a contraction that starts at 5:05, you have another one that starts at 6:05 and another one that starts at 7:05, the frequency is every hour. So frequency is the beginning of one to the beginning of the next, and duration is the length of one contraction. There's different intensities: mild, moderate, firm, and then part of uterine contraction is maternal pushing, which is at the end. So increment, a period of increasing strength. Acme, period of the greatest strength. Decrement is the period of decreasing strength. So just like they sound: decrement, decrease; increment, increase. Duration, time from the beginning to the end of that same one contraction. Frequency, the time from the beginning of one contraction to the beginning of the next contraction. And the interval is the amount of time in between contractions. And this is when the uterus relaxes. This is very important for oxygenation. You do not want contractions that are too frequently apart. You don't want them to be too close in frequency, too close together. Otherwise, the baby does not get oxygen during that time. So here's an image. So the increment is the beginning of the contraction. It starts and intensifies. Acme is that peak, and then it decreases, the decrement, and then the contraction stops. So that one contraction is duration. And then there's an interval, or the rest period, and then the time when the next contraction starts. So from the start of one to the start of the next is frequency. The amount of time for one contraction is duration. And resting is important for it relaxes the uterus, and then that allows for placental perfusion or blood and oxygen to get through the placenta and into the infant. Now, contraction phases, again, this is just a different image. So the beginning of the contraction increment, acme, decrement, and then it ends. And then the period of relaxation, and then another one begins. So from beginning to beginning, what is that called? That is frequency. And then from beginning to end is duration. So those concepts are really important to know. So this is a safety alert. Report to the RN any contractions that occur more frequently than every 2 minutes. So one to the next, 2 minutes is too soon. Lasts longer than 90 seconds, that duration, because that's a really long time to be contracting and not allowing perfusion or oxygenation. Have intervals shorter than 60 seconds, so that rest period is too short. So all of these things are red flags because the baby's not going to get enough oxygen. So cervical effacement and dilation. So 0% effacement, 50%, and 100%. So effacement is measured in percentages to 100%. Dilation is the opening of the cervix, and that's measured in 0 to 10 centimeters. So 1 centimeter and then all the way up to 10 centimeters. So this is the purpose of that first part of labor. Effacement and dilation. When a woman is ready to push, they say she is fully effaced, 100%, fully dilated, 10 centimeters. It's another image of the cycle. So you want to provide emotional support. You want to decrease anxiety and fear as much as possible. This can actually slow labor and cause a lot more pain. And when somebody's really tense, the blood flow is not flowing to the placenta like it should be. Pushing. Maternal pushing is voluntary. It can be impacted by epidural spinal anesthesia or if the mother is really tired. Women may feel the need to push before they are fully dilated, effaced, because of pressure on the rectum, but they cannot push until they are fully. This can cause tearing of the tissues, which is a vaginal laceration. Oh, the passage, bony pelvis. There's a true pelvis and the false pelvis. So the true pelvis is directly involved with childbirth. Soft tissues, if previous delivery, will yield more readily to contractions and pushing. That's why subsequent deliveries usually are a lot shorter. And a normal delivery for first-time mom is about 24 hours. Passengers, the fetus, the placenta, the amniotic membranes and fluid, the amniotic sac, the fetal head. The sutures are tissue connecting bones, and the fontanelle, those are where the sutures meet up. So there's an anterior and a posterior fontanelle. They close at different times. The posterior fontanelle will close first. The anterior will close later on. So the anterior after, and that could be up to 18 months. Both allow for molding so that the head can fit through the birth canal. So you can see the sutures, and here's the posterior fontanelle and the anterior fontanelle. So when you're assessing these on an infant, they should be pretty level with the skull. If they're sunken in, that's decreased volume, dehydration, blood loss. If they're bulging, that's intracranial pressure increase and too much fluid. That's a problem. So fetal lie, this is how the fetus is oriented in comparison to the mother's spine. These are really complicated and hard to learn, so I'm not going to test you on these, but just know that fetal lie is one description of how the infant is inside the mother. Attitude is basically how the head is positioned. So on the left, the head is flexed. Baby's curled up like a little ball. I call this tuck and roll. They're ready to go. That creates the smallest diameter possible for the infant to fit through the birth canal. When a baby's extension is an extension like the one on the right, that creates a much larger space. And a lot of times when we have C-sections, it's because there's a flexion in the presentation and in their attitude. So you want to know that flexed is the best position. So fetal lie, here's this is longitudinal and transverse. So flexion is the desired presentation. Tuck and roll. This is really just for your information in case you're really interested in this, but you put the pelvis in 4 imaginary quadrants. There's left and right anterior, and left and right posterior. So when they describe the position, the first letter is the side of the pelvis. The second letter is whether it's occiput, vertex, or back of the head. Mentum, which is like the face, mental, like teeth. And sacrum, which is a breech position, like the sacral bone. The third letter is referring to front or back of mom's pelvis, anterior or posterior. Cephalic vertex, flexed baby facing mom's spine, which is the best position. So tuck and roll, head nice and tucked, small, and facing mom's spine. So presentation, part of the body that enters the pelvis first. Most favorable for birth? What do you think? It's the head, it's flexion. So breech requires C-section. Your book kind of implies that all breeches require C-section. That's not true. So there's a complete breech, an incomplete breech, and a frank breech, which is total buttocks. And so these are some different breech positions, and you do not need to know these positions. You need to know which is the ideal position for the infant, which is a flexion position. During a contraction, duration of a contraction is the beginning of one to the end of the same, end of one to the beginning of the next, beginning of one to the beginning of the next, peak of the contraction. So it's the beginning of one to the end of the same. That's duration. Effacement. Remember, effacement is measured in percentage, and it is the thinning of the cervix. So this is 0 effacement, 50%, and this is fully effaced. Thinning of the cervix is called what? We just talked about this. Effacement. Psyche. Mental state can influence the course of labor. If a woman's in pain, if she's stressed, If she's fearful, if she's worried about something, if it's her first baby and she doesn't know that the things her body is experiencing are normal, this makes it very difficult for her to get through the labor process. So these are some of those fetal presentations I was talking about, and you don't need to know these, but this is a LOA, this is a LOT, and you just see the different positions that the baby's in. So, signs of impending labor. Braxton Hicks contractions. They become more frequent usually, but they are not regular, like true actual labor. Increased vaginal discharge or bloody show. So the cervix makes this mucus plug to protect the fetus from bacteria, and when the cervix starts relaxing and labor is impending, that usually falls out, and that could be a month before labor also. So spontaneous rupture of membranes, or SROM. The baby is at risk for infection and cord prolapse. So the sac has broken, the infant is exposed indirectly to the outside world. So at this point, if you were doing a dilation and effacement check, you would definitely have sterile gloves on. And the cord prolapse, because this baby's floating around in this hot tub and all of a sudden all the water's drained out. So that cord is more likely to get stuck around their neck. Women often have an energy spurt and could have weight loss. So the energy spurt, you may have heard, is nesting. Women have this instinct to get everything ready, and it creates this surge of energy. Spontaneous rupture of membranes. If you were testing the amniotic fluid under a microscope, you would see what's called ferning. It's pretty cool. This isn't really done that often, but it is a nice image. So there are some tests that they can do to check to see if the water broke, to see if it's not just a woman, her bladder's being squished by the baby and she just had a little bit of leakage. So those pH tests, and they're not totally accurate because they're measuring the pH, but you have to be very careful not to touch anything else that may have a different pH, especially higher. But it's color coded. And then there's these nitrazine tests, and they're a little bit more specific. So mechanisms of labor. Descent. This is when you're looking at station. Station is where the head is in comparison to the ischial spine. So when they are at 0, that's the point of no return. They're not going backwards after that. Plus or minus station, if they're 2 above 0, they'll be 2 plus, and if they're 2 below 0, they'll be 2 minus. I'm sorry, I got that backwards. If they're below the 0 line, they'll be 2 plus. And this is definitely not on the test, but just know what station is. Station is looking at how far the head has come down into the pelvis in relation to the ischial spines. So they're like -5, they move closer, they get to 0, and then they become +1, +2, +3, +4. There's engagement, flexion, internal rotation, extension, external rotation, and expulsion. So these are all the things that the infant does to come out of the birth canal. They descend down, they get to 5 plus, they're almost out. They flex to fit through the birth canal. They rotate on the inside. They extend their neck and pop out. They rotate when they're half out, and then they're born. So they come out ideally face down, and then they turn and they're looking up towards the sun. So here's the birth station. So this is how the head moves down. These are the ischial spines right here. So when the nurse is doing the pelvic checks, they're looking for the station, the effacement, and dilation. This is just another. So at this point, there's no returning. So these are those mechanisms that I just described. So descent, and then rotate, flexion, and then the baby rotates to look up, and then the placenta is delivered after. This is a video you can watch. I'll try to send it to you. When to go to the hospital or birth center. If you have contractions, if your membranes have ruptured, they're bleeding other than the bloody show, decreased fetal movement, or any concern. So this is probably in your worksheet, when to go to the hospital. So for a first-time mom, when the contractions are about 5 minutes apart for about an hour. So remember the first-time mom, it takes longer. So she can get down to 5 minutes. She should have plenty of time. Now every woman's different, but generally that 5 minutes for an hour is fine. Obviously, if the mother lives 40 minutes from the hospital, or there's a really bad snowstorm, those things are going to change when you would come in. So second-time moms, they can get down to 10 minutes apart. Baby is coming faster, things are going to move along faster. So 10 minutes for second-time moms, 5 minutes for first. So admission data. You have 3 things you need to assess: the fetal condition, the maternal condition, and is there impending birth or not. There's a skill 6-1, assisting with an emergency birth, if you'd like to look at. Admission procedures. You need permission, consents, forms signed, laboratory tests. They're going to have an IV started. They may do a perineal prep. That's less common now. So they used to shave and wash and do an enema. They don't do that anymore. Then they want to determine the fetal position and presentation. Because if that baby is breech or transverse, that's going to change what you do with that woman. You might not be hooking up to her monitors and watching the progress of her labor. You might be getting prepared to take her to the OR for a C-section. Oh, comparison of false labor and true labor. The big thing is the walking. If somebody is in false labor and they get up and walk around and the contractions go away, that's probably not true labor. The contractions are not regular at all. They're here and there. They get up and walk and they go away. There's no bloody show. And then there's no change in effacement and dilation. So if a woman comes in and she says, I think I'm in labor, and she's 2 centimeters, 10% efface, and then she comes back 6 hours later and she's the same, that it's probably not true labor. It might be her body getting ready, but it's not really labor. So true labor is the contractions are very regular and they start developing a pattern, and they increase in frequency, and they become more stronger when you walk. That's why you see women on the maternity floor walking the halls, trying to help gravity and progress labor. There's going to be low back abdominal discomfort, usually a bloody show, and that there's going to be progress with the labor. So the cervix is going to be dilating and effacing more. What is a characteristic of true labor? Contractions are regular and the intensity remains the same. Contractions are irregular and the intensity remains the same. Contractions are regular and the intensity and intensified by walking. Contractions are regular and not intensified by walking. So it's 3. They are regular and they increase in intensity when the woman walks. Nursing care before birth. After admission to the labor unit, you need to monitor the fetus, you need to monitor the mother, and you need to help her cope. And the family members or anybody that's present also. So, monitoring the fetus. Fetal heart rate. Intermittent auscultation, you're going to listen, you're going to do what's called a Leopold's maneuver, again, feel for the position of the baby, and continuous electronic fetal monitoring. So this is monitoring the baby's heart rate during contractions and continuously. So, fetal heart rate outside of normal limits. Any heart rate that is slowing or that persists after the contraction has ended needs to be reported immediately. We'll go over that again at the end. So baseline fetal heart rate, normal heart rate for the fetus is 110 to 160. Bradycardia is less than 110 and tachycardia is greater than 160. So there's baseline variability, moderate variability, marked variability, and absent variability. So what variability is the changes in the infant's heart rate. The heart rate isn't 140, 140, 140, 140 constant. It goes up and down a little bit depending on what's going on with the uterus and labor. And there should be a little bit of change or variability. That's what you want to see. Accelerations are when the infant's heart rate goes up at some point in relationship to the contraction. So if the baby's heart rate goes up at the very beginning of that contraction, that's called an early acceleration, and that's fine. All accelerations are good. If the heart rate changes at the end of the contraction, that's called late. So accelerations are okay. Decelerations or decels are not okay. So there's early, variable, late, and so that's a deceleration in the infant's heart rate at the early or beginning part of the contraction, at different points during contractions, which is fine, or late in the contraction. And then there are also prolonged decelerations, and you don't need to know the specifics of this, but if there's a deceleration that lasts 15 seconds and it's down by 15 heartbeats, then that's considered a prolonged deceleration, and that's an alarming sign on a fetal heart monitor. So moderate variable changes 625 beats from the baseline. This is good oxygenation. Accelerations are always okay because the baby's heart rate is responding by increasing, and that's not a problem. It's when the baby's heart rate decreases that it's a problem. So an acceleration, 15 beats, 15 seconds, less than 2 of those back to back, no problem. So negative, less than 2 minutes for interval to rest. This is the basis for a non-stress test. Indicates fetal movement. Decelerations, these are the bad ones. So after the contraction, late deceleration. So think of that decrement, increment, the peak, that mountain. So if it's during decrement or decreasing and they're having a deceleration. That's the placenta is not getting enough perfusion or oxygen. That's uteroplacental insufficiency. So when those contractions are starting to decrease in intensity, the baby's heart rate should not be going down at that point. So before or early deceleration in the fetal heart rate, early on in the contraction, that means that there's head compression. The head is just pushing against the body. So variable decels could mean cord compression. So as the uterus squeezes down, the cord gets compressed and then it relaxes and then it's fine. So that's variable going back and forth. So this is a little NCLEX hint. So veal chop. So variable means cord compression. Early deceleration in fetal heart rate means head compression. Accelerations are always okay. And late decelerations or a decrease in the infant's heart rate at the end of the contraction means placental insufficiency. So veal chop. Reassuring and non-reassuring fetal heart rate and uterine activity. So non-reassuring is heart rate too high, heart rate too low, decreased or absence in variability, little fluctuation in the rate. You want that heart rate to fluctuate with the infant. And then late and decelerations. And then everything on the left is reassuring. So here's an example of a left deceleration. So this is the infant's heart rate. And these are contractions. So start, increment, peak, decrement, interval for rest, new contraction, interval for rest, new contraction, a little bit longer interval for rest, and a more intense contraction. So the contraction is basically over and the infant's heart rate dips down. Now it's still okay, it's still 120, but that is what a late deceleration looks like. Late decelerations, remember oxygen for infants, for fetus, 8 to 10 liters. O2, 8 to 10 liters, increase fluids, stop the Pitocin. If the contractions are causing the infant's heart rate to go down, you need to stop those contractions. And Pitocin is augmenting or increasing contractions. And turn the patient on their side. So loss of oxygen, increase fluids, stop Pitocin, prepare to stop contractions if you need to, which would be a different medication, and then turn the patient on their side. So make sure you know this. Inspection of amniotic fluid. Color should be clear. May have little white flecks, and that's okay. If it's green stained, this means that the baby passed their first stool, the meconium. This can lead to fetal compromise, and they can aspirate on this. There should not be an odor. If there's an odor in the amniotic fluid, that's most likely an infection. And it can be documented as scant, moderate, or large. So trickle 500 mLs or 1,000 mLs. So green meconium, green amniotic fluid is meconium, and that's a bad sign. Now monitoring the woman, vital signs, contractions, the progress of labor, her I's and O's, and her response to labor. How's she coping? You don't need to know this. These are the 6 Lamaze Institute basic practices. Supine position. I remember walking increases contractions. Lying flat in a bed while your labor is actually the worst thing you can do. Helping the women cope with labor. Provide encouragement and teaching. education on medications if she's going to use medications. And remember, with pain management with laboring women, if they're doing something that is not harmful but is relieving their pain or allowing them to cope, go ahead and let them continue. So, stages and phases of labor. This is in your worksheet, and this is good to know. You do not need to know all the nitty-gritty, but you should know at least know stage 1, 2, 3, and 4th, that there are 4 stages, and an idea of the main thing that's occurring during those stages, and about approximately the duration. So the first stage, all about getting the uterus ready, dilation and effacement, roughly 4 to 6 hours. Second stage is expulsion of the fetus or birth, and that can be anywhere from 30 minutes to 2 hours. Third stage is expulsion or delivery of the placenta, and this is anywhere from 5 to 30 minutes normally. The fourth stage is recovery. So, first stage, dilation and effacement. That makes sense, right? You got to get everything ready. Then the fetus, then the placenta, and then you recover. During which stage of labor does crowning occur? So, which stage is the baby being born? It's the second stage. Vaginal birth after C-section, or VBAC. The main concern is that the scar from the previous surgery could rupture. This can disrupt placental blood flow, lead to hemorrhage. These women may need more support. Having a VBAC is okay. A lot of women do it and have no problems. It is safer if they do it at a tertiary or large hospital that has a NICU. Having a nursery like at Bristol Hospital. We do VBACs, and we are basically a NICU when we need to be temporarily. But my opinion is that women should have these deliveries at a hospital that has a NICU at the highest level and can readily get to the OR in case there's a problem. So nursing responsibilities during birth. Get the instruments ready. There's got to be stuff ready for delivery. Perineal scrub. This is usually just a little splash of iodine. There might be some medications. If they're doing a block, the pudendal block, you may need to have those medications ready to hand the OB or midwife, because that will be done right before delivery. Be prepared to assess the APGAR score, and this is something that you need to know. You're going to assess the infant for obvious abnormalities. You're going to examine the placenta, and you're going to identify the mother and infant. You're going to provide ID bracelets for them, and you're going to encourage parent-infant bonding, skin to skin. So immediate postpartum period, the third and fourth stages, expulsion of the placenta, and then the recovery. So you want to be looking out for and trying to prevent hemorrhage. And there's a lot of different things you can do that, but one of the key things is to do a very good assessment very frequently at first, and encourage emptying the bladder, because a full bladder will prevent the uterus from shrinking down to its pre-pregnancy size. You're going to evaluate and treat for pain. Observe bladder function and urinary output. You want to make sure that she can void. And if she had anesthesia, you need to recover the woman from anesthesia, monitor her response, her neurological response. And there's different things that you would do for somebody who had anesthesia and surgery than someone who did not. You're going to provide initial care to the infant. Dry them off, wrap them up, let them bond skin to skin with their mom, and encourage breastfeeding right away. So nursing care immediately after birth, care of the mother, vital signs, skin color. She looks pale, that's not good. Location and firmness of the uterine fundus. You want that fundus to be firm. You do not want a soft, squishy uterus after delivery. Lochia, the discharge, and the amount of pain. So for hemorrhage, you're going to see the signs of shock. So the heart rate is going to go up and the blood pressure is going to go down. You want to promote comfort. You want to keep mother and baby clean and dry. Provide ice or ice packs to the peritoneum for swelling and bruising. After delivery, you want to change the sheets and clean up the linen on the bed as soon as possible. You don't want her sitting in a messy bed. So, care of the newborn. You don't need to know this, but there are different phases. So, initial care, maintaining thermal regulation is the number one thing. Babies do not have the ability to keep themselves warm. They do not have the ability to shiver. So when we get cold, we shiver. Our little erecti pili muscles on our hairs stick up and we have little goosebumps. Babies do not have the infants do not have the ability to shiver immediately after birth. You want to make sure that they are maintaining cardiorespiratory function. Remember that in infants, when they're in the fetal life, their blood bypasses the lungs, and now the blood is going to the lungs to exchange oxygen and CO2. So you need to keep an eye on their cardiorespiratory function. Make sure that they're going to the bathroom. They should be avoiding 6 to 10 wet diapers a day, and you want to look for the passage of meconium. And make sure you're identifying them, safety bracelets, identify the mother or the partner or whoever has responsibility for the child and the bracelet on the child each time they go back and forth. You don't want to just assume and hand that baby to somebody else. And it's a very brief assessment of the infant. It's not a complete head to toe assessment. And definitely encourage bonding and breastfeeding, skin to skin. And what is skin to skin? That's called kangaroo care. Same thing. So this is actually called a Panda. This is a warming unit, and it's got a scale on it. So when the baby's born, they can actually zero the scale and get the weight of the baby right there. It's pretty cool. This has oxygen and air suction, where babies get checked out right after birth. Now, skin to skin, thermoregulation, very, very important. There's some more things. This is an older type of incubator. You can see the suction regulation in the container. There's oxygen right there. Oxygen is always green. You can't see a yellow canister, but they would have air. They usually mix air and oxygen for infants. And then the babies don't need to be wrapped up because there's a warming unit light up here. And here's a dad with his little one. So APGAR score. This is performed at 1 minute and 5 minutes. So you're looking at the heart rate, respiratory effort, muscle tone, reflex response to suction or gentle stimuli of the soles of the feet, and skin color. So heart rate, respiratory rate, muscle tone, whether they're too relaxed or they're too stiff, their reflexes, how they respond to you, and then their skin color. So here is an APGAR scoring. So they get 0 to 2 points. So activity or muscle tone, if there's no movement, 0. If they have active movement, they're going to get 2. If the arms and legs are flexed, but they're not really moving, then 1 point. This is slightly subjective. Pulse, absent, below 100, or over 100. And then their grimace or their reflex. How will they respond to you? Skin, blue, pale, extremely pink, or pink extremities, or completely pink. You want them to be pink. Respirations, no respirations, slow, irregular, or a vigorous cry. A crying baby is a breathing baby. So look up what a normal newborn respiratory rate is. And a lot of times infants' APGAR scores are 9. That's their best number. And it's because they may have extremities that are blue. And this is called acrocyanosis. It's totally normal in infants, but it can keep them from getting that perfect 10. So a neonate's APGAR score at 5 minutes is 9. In what category did this neonate most likely score a 1 versus a 2? And we just talked about that. That's the skin color. Acrocyanosis, bluish hands and feet. Totally normal. Administering medication to the newborn. Eye care. Erythromycin ophthalmic ointment. So ophthalmic is for eyes. Vitamin K. The newborn has an immature liver. They cannot coagulate and stop bleeding on their own, so they need a little help from vitamin K. What medication is most often used for neonatal eye care? Now, remember, Creed discovered silver nitrate prevents bacterial infections in the eye, but we don't use that anymore. We use erythromycin ophthalmic ointment. So that goes in from the inner canthus, a little ribbon, to the outer canthus of the eyes. So you can see the little ointment in their eyes. This is done immediately after birth, but we don't rush to get this done before we worry about bonding and skin to skin. So observe for major anomalies. We're going to talk about infants, newborn care in later chapters, but you want to look for head trauma, symmetry and equality of the extremities, and assess digits of the hands and feet. So umbilical cord blood banking. You don't need to know this, but this is something that some women choose to do. Stages of actual labor. So it's LAT. Latent. So that's when the cervix is dilated anywhere between 1 to 4 centimeters. And then active labor is 4 to 7 centimeters with effacement. And transition is that's the 7 to 10. The active, that should be dilation. The effacement is increasing, but you're really looking at the centimeters. So up to 4 to 7, and then transition is 7 to 10. So they're fully dilated and then fully effacement. So remember that transition phase lasts about an hour, and that's the time that you don't want to give opioid analgesics, because the infant's going to be most likely born within an hour, and then you could have respiratory distress in that infant. So that transition, the last 3 centimeters, is the very end. And then the fetus, the placenta, and the recovery. So there's 4 stages of delivery, but there's 4 stages of actual labor. Special considerations. So you want to be careful when you're talking to the mom about plans with the infant. She may be giving the baby up for adoption. She may have the baby being taken away from her. She may not have a partner, so don't ask when the dad's going to arrive. She may not have a partner that's male. And she may have substance abuse disorder and may not be taking the infant home. So just make sure you know your patient. Yay, you survived.